Good evening, ladies and gentlemen. We're just about to start now. And you are all welcome to Town Hall for this important scrutiny meeting on health and adult social care for today, the 9th of October, 2025. As the names have indicated, I'm Councillor Dr. Dominic Mbang, who is the chair of the committee. Chair's briefing notes, opening remarks. During the meeting, all participants will be in control of their own microphone. Please ensure that you turn your microphone on when you are speaking, and remember to turn it off when you finish. Very simple. All reports published as part of the agenda will be considered as read by members of the panel. Published reports will therefore be summarized to allow the panel to focus on questions. Apologies for absence. I've got Councillor Nick Williams, Councillor Christian May, Nick Davids, Joy Betsham, and Councillor Cousins, who promised she was going to come, but I haven't seen her. Is there any other apologies that I need to register? No. Thank you. Urgent business. There is no urgent business tonight. And I move to agenda 3, which is declaration of interest. Does any member have any personal or financial interest to declare on any items on the agenda? I see none. Just to always remind people, I work for the NHS, so anything that I start talking about the NHS, just be aware that that's the background. And today's program too is also, there's a lot of admissions and discharges. That is my specialty as well in the NHS, so just to pre-inform people about that. The minutes of previous meeting members are requested to confirm as accurate record of the minutes of the meeting held on the 17th of July, 2025. Is that okay? Agreed. Thank you. Now I then move on to urgent emergency care and home affairs to receive an update on the delivery of the improvement plans relating to preventing hospital admission and ensuring that people are discharged with access to the support and settings that will support their independence, especially, for example, reablement, and to review the quality of models of care, including residential and nursing homes, with a view to making recommendations to the executive if appropriate. So those we are expected to attend, I have here, if I can start mentioning, we've got our Cabinet Member for Health and Adult Social Care, Councillor Loliver. I can see you. You're welcome. I have Lisa Wilson, also Integrated Director of Commissioning and Adult Services. I also have Rachel Matheson, also Associate Director, Adult Community Physical Health Services. And also, I think we have two who haven't. Gabby and Samantha is not here, isn't it? Thank you. Is there any person? Mike Corrigan is also here. Yes, also Assistant Director, Social Care Operations. Jessica Arnold as well, Director of Primary Care and Neighborhoods. We have the director in the house here today as well. Thank you all for coming. I'll leave. I put everything to you, so the ball is on your court now to.
Thank you, Chair. I'll start. So Lisa here. I will just give an overview of our approach to partnership working and then hand to Mike on discharge and those matters, and then briefly to Rachel on Home First. So it's first important to say that we work as a whole system. So although the Hospital Trust aren't here tonight, we've got representatives from the Community Trust and obviously Adult Social Care and myself in an integrated role working across the system. We've been working in that way for some time in terms of that leadership coming together, and that's a really good thing in Greenwich, because I've been in other systems where we don't have that alignment and leadership working quite so closely together. So the things that you hear us and you talk about and the things that you've read in the report are in the context of us working together. That leadership has been expanded in terms of how we work. So we undertook a review of our urgent emergency care and admission avoidance pathways, and we're now working as a leadership alliance across those organisations to make sure that we really stand in each other's shoes, spend time together and act together as well. So that's the leadership aspects, and I'll hand over to Mike, who's going to cover discharge in summary as well.
Thank you, Lisa, and afternoon, Chair. I just want to talk the reference to the discharge and flow component of this report. And as Lisa says, it is evidencing the joint enterprise across adult social care, Bexley's, Oxley's Trust and the Queen Elizabeth Hospital. As a consortium, we're working together to ensure that any patient entering the hospital, their discharge is coordinated with the focus and aim of the return to the person to the place that they want to return to in the most timely and system-driven way. We, following and implementing advice and guidance from the Better Care Fund review that was undertaken recently, which identified a number of themes and principles, but the key points that we are taking forward as a consortium is around the current processes, which is called Transfer of Care Hub, where there is regular meetings in the hospital where people are discussed, where support or any blockages are that prevent discharge are addressed. And then the other sort of aspect which we're moving towards is the development and creation of a discharge hub, which will help us utilise much more coordinated the skills and enterprise we have in each of our organisations, but bringing them together as one, so that when a person is ready for discharge, they will be referred to the hub, and therefore all the services and organisation and skills that each of the four services have will come together to help and support the person in the promptest and quickest way. The development of this hub, discharge hub, will be a great aid in achieving our home first approach and will enable a much more structured and coordinated utilisation of the resources we have available to reablement services, a facility known as Meadowview, which is a hospital reablement service, but also community assets. The intention is over the next year, because we have appointed the lead for that, we appointed last Friday, the intention over the next year is to build up the expertise in the hub and hone our practices and approaches so that we can involve the community, voluntary sector, housing, and a range of other external agents and support systems so that the community itself and the person and their family become part of the discharge process. And we would hope that by the end of the year of the person being in place, we will have established quite a systematic and unique integrated approach across all professional organisations to address the needs of the individual at the point of discharge. We will, once we've sorted that discharge process, be tackling the next issue that was identified in the Better Care Fund review, which is about admission preparation and admission avoidance, but taking it systematically. The task now is to ensure that discharge is done seamless, prompt, and in a timely manner to meet the needs of the individual. I'll pass over to Rachel now.
Mike, so the report mentions about the primary and secondary care interface forum that has been established. So I work in the community services for Oxley's, for the adult physical health services, but we work really closely with the GPs. So we've done lots of work with primary care. Jessica's here anyway, but we've been really strengthening that approach. I have a role as a clinical care professional lead as well, which connects me with the GPs, and there's another CCPL who works leading the primary and secondary care interface. So the relationship between GPs and the acute hospital is being strengthened through lots of the pathways there. I wanted to just mention some of the services that are in the report in terms of hospital, people avoiding hospital, but also being able to be discharged more quickly. So the Joint Emergency Team is an integrated service that we have at, it's based at the Woolwich Centre. It's integrated with health, social care and with social prescribers from Charlton Athletic Community Trust. We've even got a handy person in that team. It's an incredible service that means that we can deliver urgent care to people from the community, but also pull people from the SDEC or the hospital so that people can not be admitted if they present to ED. We're really proud of that service. It's extremely responsive. We have a 100% response rate within 2 hours of referrals for urgent responses. We also deliver virtual wards in partnership with the hospice, who also have a virtual ward. And with our RBG colleagues, we're able to support people with COPD, with end-of-life care. We have a children's hospital at home service. We have a virtual ward through the JET team as well. So we are able to pull people from the hospital, but also have a focus on admission avoidance. Some key roles within that are our care navigators. And Mike talked about the Transfer of Care Hub. These particular roles are nurses and therapists who work into QE hospital, and they will support people to be discharged earlier from the hospital and to get back out so that people are at home being, recovering in their own home as quickly as they can be, with whatever services they might need that we could offer to support them. We have a similar service supporting care homes, our complex case managers, who will support people so that they are able to remain in a care home as well as possible and not need to go into the acute hospital either. And then I wanted to just mention our frailty team, which is a really core part of some of our services to avoid hospital admission. So we offer a service for people usually referred by their GP. The person would be assessed and with a comprehensive geriatric assessment, and then hopefully we would put into place lots of care to support that person to optimise their health, to engage in community services because we have social prescribing as well. And it has been proven to reduce people going into hospital, calling London Ambulance, and to be happier with their health. So it's been a really successful admission avoidance service.
Thank you, Rachel and Mike. So just to summarise the final bit of the report, we were asked about the quality of care from home care to also reablement and nursing and residential care. So in Greenwich we have a large supply of home care in some ways, but also strategic relationships. So we have a framework of providers who cover different neighbourhoods, and they also cover our extra care schemes, of which there are 3 in the borough currently. We do have an aspiration to develop more, and it's one of our strategic priorities and political priorities as well. In terms of home care, we've learnt a lot over the last few years over what people say matters to them and how our home care supports them in their own homes. And we continue to take that learning into account as we go forward. We've got a range of other providers that are smaller in the borough, and they work with people who perhaps have self-funded care or direct payments, and also when we need some resilience in the market or choice for people with particular needs. Those are known as spot providers rather than the framework ones, and we work with them. Overall, we see good quality. We have had some, as in many places in the country, quality issues with provision, but we're really quick to step in and support providers with our quality assurance process, but also the way that we build into these contracts the sorts of mechanisms to ensure workforce recruitment and retention and pay. So for our main home care contracts, we pay London Living Wage, and we also make sure that those providers reduce the number of zero-hour contracts and those sorts of things. So those are really good things that we put into those contracts, but we monitor them really closely to make sure that we get what we need from those providers in partnership. When we come on to the integrated neighbourhood teams that Jessica's going to talk about, I'll touch on some of the transformation work that we're going to link up. On reablement, we have an in-house service and complemented by Oxley's in terms of therapies. We've done a lot of work to improve that service. Mike is now leading a short-term review to maximise its effectiveness, but we're taking a longer-term look at that. We're saying, actually, what is that model for the future? Is it a bit more like a hybrid model with some of it in-house and maybe some of it commissioned alongside with our home care provision? That's quite a common way to deliver reablement. We're one of few places in the country that fully have it in-house. So the recommendations from that review will be coming in November. Briefly on care homes, we have 11 in the borough. Quite few compared to some places. When I've worked in other authorities, we've had hundreds of care homes. So for me, it's a really good place to work, actually, where we've got that relationship with our local ones. And we've got some in a bigger contract known as a private finance initiative. So there are neighbourhood resource centres, and then we have a number of other providers that we work with. They're pretty much overall good providers. We have one that's at the moment seeking to improve from requires improvement to good. And we've seen some significant progress when we've had providers who've had concerns. There was one in the last couple of years that was inadequate, and they actually moved up to good with the support from our quality assurance team and the partnership work that we did, as well as the CQC stepping in. So we've got a really good foundation in terms of how we quality assure, as well as have partnerships with our providers. And as we go forward, we continue to maintain those. It's really important, though, that we forecast and we look at our needs of our residents and the population. So we do that in terms of thinking about shaping the market and encouraging providers that are of good quality, but also, importantly for social care, if you go back to the Cooperative Commission that we led last year politically, and Marion steered politically, what we really want to do is make sure that we're working with providers who have ethics and that they're working with their workforce as best they can, but also they're not using kind of private equity in unhelpful ways, which we know is a feature of the adult social care market. So I wanted to mention that because it's really important for us to work with ethical providers. Thank you, Chair.
Thank you very much for your presentations. I will now open questions to come to the panel members first. We have received 3 questions from the general public, which is relating to this agenda. So before that, I will ask panel members if you have any question to the presentation that we've just heard. So that's open.
Thank you for the presentation. There's quite a lot of information to take in there. I'm thinking this is the first of its kind, is it? This is called the Urgent Emergency Care and Home First. Is this the first of its kind? Or
so we have national and statutory requirements to deliver urgent community response services that Rachel talked about,
Right.
and those range of community services. And the urgent and emergency care side of it is the interface that we have with the hospital. That's common across the country. It's required that we have those things, but our local approach is tailored to us. So it's a statutory requirement to have these services in place. How we deliver them locally is up to our partnerships to make sure that we meet those needs.
but what I'm saying is that this is the first, it's been rolled out, this is the rollout process, is it?
The improvement work, yes, there's a particular programme that we mentioned in terms of the Better Care Fund supporting us. That's the first time that improvement programme was kind of set ahead in that way. But we had these services in place. It was just we continuously improve, so that programme was to support that.
And I just wanted to say, would it be possible to see figures or going forward how they will be implemented, and just the statistics on the real people that are going to use these services? Just be nice to see the reality of how it works and going forward.
Can I just share? We've got some videos of residents as well that we can share with you from some of the Home First work that we've done and the virtual wards, so we can send the links to those.
Councillor Matt Morrow.
Thank you, Chair. Thank you for presentation and input to the report, which was very useful. Could I please ask what are typical obstacles to early discharge that you're finding at the moment? So, you know, or indeed not taking somebody to a hospital for treatment at the moment. What are the obstacles that you're currently working on? And I suppose in a related way, are there any further partnerships you're working on? Because I think you referred to a health system, which sounds like a really, I mean, that is the right way of seeing it, isn't it? Health is not what happens in a hospital, it's everything. But and you currently have strong partnerships with, I don't know, Greenwich and Bexley Community Hospitals and so on. But are there further partnerships that you're working on? And finally, could I ask, how are you measuring success? Because I do like you know, an overview and a management plan, but you know, if you get to 2 years down the road, what are you going to be saying? It did work because of this number, or it didn't work because of that number? You know, how would you measure that when you get there? Thank you.
So I think, Mike, if you take the question around the discharge side of things, and then I think, Rachel, you're best placed on avoidance in terms of obstacles, and obviously there'll be partnership aspects. If I then specifically talk about some of the partnerships, I don't want to cross over with what Jessica's going to do in the next item. And measuring success, I think we can come back to as we go through the answers.
Thank you. Very interesting question. I mentioned the system because people do live in the community in the system. It's not just a sole sort of enterprise. So we're looking to develop further interaction with our housing colleagues, voluntary sector partnerships, with the providers themselves, but also bringing in adult social care, children. There's a whole myriad of groups in the community that we can work with. Community groups, community navigators, and the intention through the discharge hub is to reach out and develop a sort of a series of interactions that can assist the person with the appropriate response to their needs. Because again, we're really conscious that the individual will have different aspects of their life that we need to consider. So there's aids and adaptations that need to be done. There's potentially networks and loneliness to be dealt with. So it's actually wrapping around with our partners in the community, the person, so that we can get them home to the place they want to live in. So it's not a defined group of people, but it's quite an involved and fluid group of professionals. As examples, we've talked to individuals and they've talked about their faith groups. So moving forward, we want to have links with the faith groups through the neighbourhood work, and Jessica's going to talk about. So we've got easier and prompter access to faith groups for particular people and particular needs to be met. So it is a very fluid, there's not a one-size-fits-all answer to your question, which is a good thing, because it's about us being agile and able to harness what's in the community to assist the person for discharge. I hope that's an appropriate answer. Thank you.
Thanks,
Yeah.
Lisa. So
You want to carry on?
You asked about obstacles for, is that obstacles for discharge from hospital? It's so dependent on the individual. It's really difficult to be able to say. It links to Mike's answer, really, because I think we all need to be aware of what is important to that person to get them home. Sometimes it can be getting a care package in place. It could be setting up an appointment with a district nurse. It could be getting a hospital bed put into somebody's home. It could be anything. So it's really important that it's tailored to that individual, which comes back to the transfer of care hub that we're developing at the moment. So at the point of discharge, we've got all of the relevant parties there supporting to make sure all the things are put in place for somebody. In terms of partnership working, I think for me it's about working with the voluntary sector going forward. So in our frailty team, we have got Age UK partnering with us, so they're integrated into the team. They're the social prescribers for the service. They're amazing at navigating people to all the different services that will help them. Often it's about loneliness. It might even be about, I've had someone that went to a knitting club. You know, it's connecting to the things that really matter to people. And that frailty team, we have measured success through a number of different data sets. So people ring the ambulance less, they have less days in hospital, they have less admissions in hospital, and they are happier in themselves. So we've got a lot of data around that in terms of measuring it. But we do also measure patient and carer experience as well, which is positive. So we have a lot of measures to show that.
We do, and we have a Home First strategic board, Councillor Morrow, which receives that data. So we have a Home First dashboard where we look at the key metrics, but also on the discharge end, we have something called an urgent emergency care board, which goes across the trust area and covers our footprint in Greenwich. So there are national metrics we have to meet as well as local, and we look at that data together, and it's part of the work when we did the BCF support programme. We're reflecting on how we measured against the key metrics. We saw at that board this week, actually, we've seen some improvement in terms of the performance. Lewisham and Greenwich Trust for discharge metrics were not in the best place, but we've seen a real shift through this partnership work, and that was highlighted at the Urgent Emergency Care Board this week, where you could see where we were in the national tables as a local system. So I think there has been a lot of improvement, and partnership work is obviously key to it. But like Rachel said, we're expanding those partnerships all the time and connecting up, and I think part of what Jessica's going to talk about reflects that. Just on barriers, I think there is something about public expectation. So sometimes it is about the story, about what people want from going home, and whether the choices that they're making are ones that are available to them or not. So some things like mental capacity, or people understanding the choices that they've got and the choices of provision in the community, sometimes that's a barrier. People might want something that actually for their needs isn't the best thing, and then we have to negotiate that with families and things like that. Some of the kind of nitty-gritty of getting prescriptions ready for discharge and those sorts of things, but that's all part of that TOC Hub development work. So we're hopeful that, you know, where things aren't working, we're now working really well together to improve.
Thank you for those answers. Any further questions? Councillor Tessa? Mike, yes, go ahead.
Sorry, Councillor. What the most important thing I should have said to you in response, and I forgot shamefully, is the family themselves. And when we talk about partnership, it's the family and the important people for the patient, that the development of the hub and having a range of different professionals, it allows the family or the person's friends to actually talk to who they feel most comfortable with. So, you know, they should have been the first thing I replied to you. The person and their family and the significant others is the most important element of, you know, how we make discharge fit the person.
Councillor Testa, any? Yes, go for it.
Sorry, guys. I just wanted to ask if we have residents who feel they're not getting the treatment that they deserve, is there a I don't know, complaint department or anything that we can refer people to if they fall through the, you know, the gap, so to speak?
Yeah, my advice would be to contact the PALS service at Queen Elizabeth, or Oxes have a PALS service, so Patient Advice Liaison Service, PALS. Yeah, you should find it on the website for the hospital.
Thank you for that. Councillor Jedia, you don't have any question? Yes, I think you are hitting on a very important subject today, an area that really, really saves the NHS a lot of money if people are able to move freely and the NHS can function better. The question I want to put across is, what is your day-to-day discharge like at QE, especially when it comes to, you know, the NHS has it that they will quote amber, they will quote green, amber, and then red. And I just want to know how it is been, what is your experience at Queen Elizabeth here? And also to help those people who possibly are discharged and not returned back, what are the areas that we've got in place? I mean, do you have befriending services, people who can help people to stay hospital at home? Could you just comment on those for us, please? Thank you.
Ironically, Councillor, Rachel and I were with our colleague Josh from QE Hospital last Friday, and he was quite elated because he said it's the first time in a long time that actually there wasn't a pressure at the hospital for beds, and we had what he called an equal status. So there was no waiting, there was no sort of queuing, and he was actually really sort of, you know, to be honest with you, he was very, very elated because he said it was new to him in his career. So, and that he also shared with Rachel and I, that's as a result of the joint work we've been doing over the past few months, because there have been developments, there have been new ways of working. And Josh was sharing with us both, he's seeing he's cited in the hospital, his role is to deal with hospital flow and patient discharge and admissions. And he was very clear with us both that part of the excitement he had was based not just on the fact that numbers were, in his words, excellent, so there was no sort of delays anywhere, but it was the pleasure at the joint work that's taking place at the moment across the system. So I don't know if you want to add to that, Rachel, but it was quite an exciting opportunity, a moment for us all last week.
Absolutely, he was really pleased. I mean, it's challenging in the acute hospitals, and you know, I think they'd had a ward that was closed because of infection control reasons, and you know, these things happen, and they'd been able to reopen. I think they work very well in terms of adding in support under pressure. So yeah, we were pleased. We'd taken a partnership approach to that, so it was good. Your second question, Chair, was around discharge, when people are discharged and they don't return, so we're hoping that they don't go back to have another admission. So we do have our virtual wards that have been set up, which can bring people out of hospital sooner, but support people as well. I mean, nobody should be discharged too early. You need to be discharged at the right point. So our JET team has a virtual ward, and we can look after people at home with some technology. So we have some remote technology that looks blood pressure, SATs readings, etc. And we also have point of care testing, which means we can do blood tests on the spot and get results quickly if people have an infection that might need antibiotics, for example. So we can put all of those things in to try and prevent somebody going back into hospital. But if somebody is under the frailty team, they get a lot longer support, so they might get support for 2 to 3 months. So really hoping that someone optimises and they don't need to go back to hospital. We're really focusing on that at the moment.
And if I can just add, Chair, just briefly, when I mention reablement, that's the when we discharge people to recover and hopefully maintain their independence. It's a really important service because that's for up to 6 weeks, and it's a therapeutic-led approach. So I think that's part of it. But then our digital health and care technology service, as Rachel said, you know, we've seen some great outcomes already, and we're only 6 months into delivery. So I think we'll come back in time and share that as part of the agendas that we've got in the future. I think there's a space to do that. But some of these new models we're now learning the effectiveness of, and that we're starting to see that. I just wanted to mention one thing that has been a really good piece of partnership work. So when we think about people avoiding admission, sometimes it's when they get into the emergency department that you find out actually that's not where they need to be. So we have the urgent treatment centre that our primary care colleagues run, and they do this screening to make sure that people, before they even sit in the emergency department, actually see whether that it could be dealt with in a different way, either in primary care or other services. And our Live Well service has been doing some of that work in the emergency department to catch people there and say, actually, are there things in the community that you need rather than being here? And the new development that we're seeing come through, and we'll hear more about, I think Mariam's going to be promoting some work that we've been doing. We've put some Section 106 capital in as part of our partnership work, which was designated for integrated health services, into improving what we know as the streaming space in the hospital. So by the end of this calendar year, we should have some extra space for that urgent treatment centre to help the kind of dignity and the effectiveness of that urgent treatment centre and the pass through into other services. So a really significant improvement that we hope will improve that kind of admission avoidance end as well.
Thank you very much. I think I just needed to add about, to mention or find out what the situation is in the borough here as well, and that is about homelessness. We know it's a big problem in London here, and I also know that when people come to hospital, housing has become a bigger thing that makes people to stay really long. And apart from that, we also have a situation where people are not, they are not people who are, the system cannot support them because they are not documented. They have no recourse. When you come across those difficult scenarios and complex cases where it's just not local authority, but the ICB will also have to be engaged. How do you deal with your cases locally here? And what is it like within the Royal Borough of Greenwich here? If you can share that with us, please. Thank you.
Councillor, I mentioned earlier when I was presenting something we call a transfer of care hub, which we meet weekly in the hospital. And we have a process agreed between Rachel, myself and QEH Hospital, where if anyone reaches a sort of a red flag point of delayed discharge, then we get involved. And we personally sit down, understand where the blockages are and what we can do to eradicate them. And part of Josh's pleasure last Friday was based on the fact that we didn't have anyone in that position with delayed discharge. It's very hard to describe the approach we take because each person's needs is individualised, but the aspect of having myself in adult social care and then the context I've got in the council, Rachel in the community health, and then Josh with, again, community nursing approaches, we do have the ability to call on partners to deal with any. So if it's a housing issue, I will liaise with the housing department. If it's an issue around an adaptation to a property, again, I can do that, as can Rachel. So as a system, we then reach out with what is causing the delay, what is causing the inability to discharge, and then we can deal with it. But there's a lot of work goes on by staff before that point. It's just the commitment Rachel and I have given Josh that the key, and I think, God, it's awful, the date, I think it's 28 days. When they hit a figure of 28 days post being told you're ready for discharge, that's when Rachel and myself get involved as senior system leaders to deal with it. We try, and there's times we do get involved because, you know, some things we can't always meet every need within that preceding 28 days. But I'd say the last 6 months has been a much better approach because of the integrated working across the system. And we also make use of facilities we commission from the voluntary sector in the community. Because sometimes there's a delayed discharge because the person themselves might be feeling lonely, vulnerable, isolated. So we utilise our colleagues through commissioned services in the voluntary sector, Age UK, Living Well, to assist the person to take them home and reach their sort of requirements for a safe return home. So I think that's the system we operate is quite a system owned. It's not a hospital problem, it's our collective requirement to support the person with delayed discharge.
I think you asked a question about homelessness as well, and we had quite, so Rachel, remember this from some time ago, there was a service in Greenwich and Lewisham and across other areas of South East London to support people who were homeless and turning up in the emergency department or elsewhere in the hospital. Whilst that service specifically no longer is there, actually the learning from it means that the capability and the understanding of what to do is invested now in the staff in those different settings. But they also then link out to other voluntary sector organisations and others that deal with homelessness issues and our housing department as well. The other aspect of that, and you mentioned those that have no recourse to public funds, we do have a team in adult social care who support people, and we also have the links out into other organisations that we fund to support people who don't have that recourse. So that's part of our duties, and we have that in place.
Thank you. I asked that question because I think it was on the good note that from our experience from the specialist hospital, when we're dealing with people who are within the local authorities, Greenwich actually deals well with their homelessness and people who are, are having housing issues. The time they use to respond is really, really something that I just have to say, well done for that. That is from us. I will ask, there are 2 questions that came from the general public, 3 actually, and they are all linked within the social care side. So I will ask that while you are here. The first one is from Councillor Cousins, who says, on service standards and evaluation, how does the council ensure good standards relate to what is needed in adult social care? That's the first question. If you could, and then the second question is, does the service provided work to create dependency or independency, and how do you ensure it is the latter? I think someone has already touched on the technology and the rest, but if you can possibly comment on that, and then I'll take the last question later on if you answer these 2. Thank you.
So if I take the first question around quality standards, we have a quality assurance board that Nick and I jointly chair for adult social care. So we look at the quality of the provider market, we look at the quality of our practice in social care, and then we also look at the safeguarding aspects of our quality and oversight in that one board, so that we bring all that together and we look at the data, we look at the case examples, and then we have action plans in place where we see there's a need to improve. And we also have been revising our policies and procedures, so we've got quality assurance framework that's just been going through a review, and that is coming to fruition now in terms of being signed off as a new kind of joined up approach across those three angles that we look at. The other thing that we do though is work with partners, so we have a provider quality assurance board specifically that we've just refreshed, and we've got primary care, secondary care and others, and the CQC that we work with. We've got really good relationships with the CQC locally, so we know the local officers, we connect with them around our quality, and when they flag things to us, we then react to that as well. So I'm really proud of our quality assurance approach. I don't think other places are quite so lucky, and I think again it kind of points to that partnership approach. In terms of dependency or independence, obviously we've talked about that broadly, but I think between Mike, well, if Mike starts on an adult social care point of view, obviously Rachel in some of the integrated pieces as well.
Chair, with regard to the question about dependency or independency, we are very heavily focused on a strengths base of interaction with people, and we focus on the person's strengths, what they can do, rather than the deficits in their life, with then an emphasis on what is preventing them living the life they choose, and then we build support around ameliorating that issue that's preventing them living the life they want, rather than creating dependency. A key sort of aspect for that at the moment, and Lisa mentioned earlier, is the use of technology, aids, and sort of creating independence, choice and control for the individual, where we give them tools and equipment alongside personalised support that enhances their ability to live their life the way they want to. We also operate a very structured review process if a person is supported, and that again gives quite a granular and detailed look into is the person's interaction with whatever support they're getting based on enabling independence, them living the life they want, or does it focus more on we do to people, not with them? If it's the latter, we change it, because our relationship with our providers, as Lisa said, is very good in Greenwich, and so a strengths-based model to create an environment within which the person has positive risk management, positive opportunities to be in control of their life is how we operate. So it is quite a sort of dependency, we're anti-dependency approaches in how we work with people. It is all about strength-based, live the life you want to lead in the way you want to lead it, and we actually support you to get rid of the obstacles to achieving what you want to achieve.
Thank you, Mike, for that answer. I think Councillor Cousins should be watching this live, and she should be satisfied with the answers that were given. Thank you very much for that. I'll go to the last question, which I think John Kenny is actually in the room today. Are you? Yes. Should I read it, or you want to ask the question? Should I read your question? Yes. If you can come this way, and then there's a spare one here. Yes.
Thank you. Is the mic on?
Yeah, it's on.
Oh, good. Okay. Thank you. Just very brief background. While we still had a CCG here, I was a member of the patient reference group, which was a scrutiny and oversight panel. I also took part in what used to be then called the frailty group, which then became called the home as a priority group, which were forerunners to the programs that are being rolled out today. Clearly, there's been a long lead-in, a lot of aspiration, and we're right in the midst of transition. I've been through reorganisations, both as an employee and as a senior person in an organisation, the trauma it can create amongst the staff themselves and managers and turnover and new jobs. Throw in COVID, and frankly, my view at the time, when we became a South East London CCG prior to becoming an ICB, in my view at that time it was unforgivable to carry on with that reorganisation during the COVID years. That was my view, and I think that was echoed by a great number of staff at the time. It took a great toll both on the organisation and the spirit of the organisation. That's a little bit of background. I also, many years ago, as part of my career in housing, attended what we called meetings in the neighbourhood. That's over 30 years ago, at which GPs, representatives from hospitals, housing providers, voluntary sector, social services, took part. These were public sessions, they were consultative sessions, evidence was brought back to regional health authorities, etc., etc. So I'm not saying I've heard it all before, because these are great aspirations, and there's a lot of hard work going behind them. But I think if we honestly say, and I'm surprised we haven't got a hospital representative here tonight, much of this discussion post the report, summary of the report, is around discharges and admissions. And having got to know Ben Travis quite well through these forums and so on, the last time I met him at a public meeting like this, his view was, there is a crisis. His word, not mine. I don't believe that crisis has subsided in the last 2 years. Given all this hard work, no doubt about that, the duck's feet are flapping really, really well, but there's a heavy current, and some of that's around resourcing, finance, cuts, abolition of NHS England. So it's very difficult to conceptualise and be frank about just how difficult it is for you people to summarise just the churn and the reorganisation that's going on. What concerns me is the evidence. So I'm surprised the report didn't talk more about what I would call delayed admissions and premature discharges. Given my background, I have a network of people who've worked in similar areas. I cannot be the only one who are hearing repeated concerns and distress about being discharged almost on the day they're being admitted.
Kenny, we got where your background and your questions, you've rightly put it here. Would you now go straight to the question?
I just wanted to give 2 examples. Provision of a hospital bed.
Yeah.
The person I have in mind was, before they became ill, was having extensive building works carried out. They had no kitchen. The place was a building site. But still, against that patient's will, they were visiting the house and trying to persuade a relative to allow them to go into the home to measure up for a hospital bed. So that's one example. Second example, readmissions, premature discharge, readmissions. A person collapsing several times, admitted, discharged within 24 hours, readmitted within another 48 hours, and then in hospital for what should have been the 7 days that person needed on the first occasion. The pressure on that hospital is absolutely immense, and on staff, and it shows. And what I witnessed in one of those cases was a little less than thuggish behaviour by the people, not persuading this person. They were stabilised. This is the word that's used now. Not sort of...
So, Kenny, your question has been asked now. Could we
Okay,
allow them to respond? Because I'm working with time and your time is up. Thank you very much.
Fine. Okay, so that's context. There's a great deal more that I think the report doesn't address.
Yeah. And we will also, I mean, we don't mind if there's further information you give it to us. We'll make sure it gets to the appropriate. So could somebody respond to about the delayed what do you call admissions and pre-discharges that makes people to come back? I think I did touch on that when I asked my question, but I think his question is straightforward. Could someone comment on that, please? Thank you.
I just thought a specific type of service might be worth mentioning, because that example where you said somebody's bed was being measured up and their environment wasn't fit for them to actually return home, it sounded like. We have something called a step up, step down type provision. Mm-hmm. And we have some of those in the borough where people, if they're being discharged and their home environment isn't suitable, we support them to live in another environment for a period of time whilst all of that happens. Yep. That site is at Langton Way at the moment, that step up, step down provision, and it's really effective. We look at that data in terms of making sure that people don't go home into those sorts of environments wherever we can support that.
That's where that person eventually went.
Yeah. So that...
But not until they tried to, against her will.
So that's an example of actually a really good service that we're trying to actually maintain, and we're looking for where else we can make sure that is provided, because Langton Way is where we're looking at some of our extra care provision potentially going for the future. But for us, it really is about trying to make sure those things don't happen. But unfortunately, there are examples everywhere in the country where we don't get it right for everybody. It's the learning from that I think is important, John, and I think we as a system are taking a lot into account in terms of the learning. And going back to the data on readmissions and things like that, I think Rachel touched on that. But part of the BCF programme work was looking in depth at all of our data, and externally we were scrutinised on that by the Better Care Fund programme team, experts in this field nationally coming and reviewing our work locally. So the improvement work in this report is as a result of all of our data being scrutinised around these aspects, and with the improvement plans that we've now got, taking into account what we need to change.
Yeah, thank you, Lisa, for that response as well. If you could just put that off. Just put that off, that's fine. Great. I will move swiftly. Do members have, this is the panel members, do members have any recommendations they would like to submit, apart from what we've heard tonight? Yes, go for it.
Thank you. Sorry, I just wanted to say, it's about working with the hospitals, isn't it? Because I know, for instance, some people who are admitted into hospital are normally better, I've spoken to a few people, are normally better within a couple of days, but they're kept for about 7 days longer. So whereby they could have been discharged. I just wonder about working with them. I don't know what the solution is, I'm just saying.
I've talked a little bit about our in-reach staff that go into the hospital. So we're hoping that we can get people out as soon as possible, because the longer people are in, you're deconditioned, aren't you? You might be ready after a couple of days to come home. So it's our nurses and therapists that are going in. We hope that they can go onto the ward, see people that are ready to go, and put in place those things that mean that they can get out earlier. So that is definitely something we're doing. Thank you. It's a good question.
And apart from actually blocking the, what do you call, the A&E, because you are having a situation where people are not leaving the hospital, hospital-acquired infections are the things that I believe if people are moved in time, then that will be absolutely great, so that we'll be able to. I will give the chance to Francis. If you can come forward to ask your question, then we'll move swiftly to the next agenda. That will be the last question. Thank you.
Thank you very much. Before Health Watch came, some of us were in Link, which was the patients and public sort of oversee, and a couple of us did a review or survey on the discharges into the community. I don't know if anybody were about then. A lot of them were lonely on their own home. Most of them, I think, were more of the older age group. But the time, we even got the time that they were discharged, what was home, and it was not a very good report then. What concerns me now is they've got the heating bills, they've got extra, it looks to me that the government has put a lot of the economics of being at home, who does the washing, who does the ironing, because I'm sure a lot of them are on their own. That seems to be the society, and probably in the older age group. So I don't know what's prepared for them to make life easy. And I think we had a lot of prevention, and prevention is very important. We had home helps, we had luncheon clubs, we had health visitors, and all those people worked together and prevented a lot of illnesses and loneliness as well. And so I think we should look back to prevention again, but also be aware of what you're sending these patients out to, the economics of it all, and who's actually able to be their supporter. So that's all I want to add, a bit of the overall of living.
Thank you, Francis. If someone can.
I think there's a really important point there in terms of carers as well. So, some people have those networks, family carers and others don't. And I think you really shared that point well. We do have a range of support for carers as well as those networks, and I think that's important that we bring that out in the conversation. We're going to cover, I think, quite a lot on prevention and some of the proactive care in the next report, but Rachel, did you want to say something?
Well, no, it's just more specifically about, it's linked to both questions really, the frailty team that John had helped to shape in terms of some feedback in the early years, but the service itself has run for 5 years now and is across the whole borough for people to be referred to. And our Age UK care navigators in the team will link people up with all of those services in the voluntary sector, including if they're struggling with bills or food parcels or other things that are social issues, befriending, everything, social clubs. So I think it's been really recognised that health alone and social care alone cannot, fix some of these issues. It's about all of the wider social determinants. So that our model is delivering that now, and we're hoping to expand it. So
the only other thing on economics that I think is worth noting is that we have something called Greenwich Support, and it's a range of multidisciplinary team approaches where welfare benefits and some of those voluntary sector organisations and the clinicians or social workers come together around particular cases where it is about people's financial resources as one of the barriers, and then we connect them out to that support. So that's been kind of making every contact count type approach in that Greenwich Support's work, and I think we'll kind of touch on that in the neighbourhoods work as well.
Thank you all for your responses. We'll move swiftly to Agenda 6, which is Health and Social Care Integrated Neighborhood Teams, to consider the update on the development of integrated neighborhood approaches to delivering health and social care with a view of making recommendations to the executive, if appropriate. So we know expected people to attend. Same people, yes. I think we've got, I think it's just Gabby who is possibly not here, and then Samantha too is not here, but the rest of you are all here. I would like to give you the opportunity to present to us on this agenda. Thank you very much.
Thank you very much, Chair. Good evening, members. So I'm Jessica Arnold. I'm the Director of Primary Care and Neighbourhoods within the ICB. I know that updates on integrated neighbourhood working have come to this group before, so I'll assume a level of knowledge and take the paper as read, but I will pull out key areas of progress. So I'm going to talk a little bit about some of the progress we've made around shaping our neighbourhoods in Greenwich, around some of our priority areas of work, pathways and services, which the previous questions segued nicely into, and then some of the enablers that are going to take us to where we need for the future of the neighbourhood health service. So firstly, to think about what neighbourhoods look like in Greenwich. If you've been around for a long time, you'll know that different geographies have been applied at different times. If you go back far enough, clusters and localities, primary care networks, the way social care and community services and general practice and hospital operate have all been on different footprints. We've been looking at what is a meaningful way for Greenwich residents to think about neighbourhoods. If we took neighbourhoods and the places that you think you live, where you would describe somewhere you live, we'd have 27 in Greenwich, and that's just not feasible for wrapping services around. So where we've landed is that we have 4 neighbourhoods in West Greenwich, South Greenwich, central east part of Greenwich that we're in now, and the northeast part. We're looking at the moment around how our practices, our general practices and our pharmacies in primary care sit within those neighbourhoods. In some cases, they've worked very closely with their other colleagues and partners in primary care in those areas. But actually, the geography of Greenwich has been quite messy, so it's not always been the case that the general practice up the road is one that you might have worked with in yours. So we're doing that mapping through. Colleagues are also mapping through our home care provision. So Lisa talked about the home care providers in different parts of the borough and how they're working closely on a neighbourhood footprint. And I will come to what the purpose of this is in a moment. We're looking at community services. So Rachel has talked about that. So district nursing teams, for example, and others, and how they are configured to support practices, to support people in those areas. So why reconfigure these teams and come up with some rather nice maps of what that looks like on a 4 neighbourhood basis? Really important that we are able to take the opportunity of the national directive, the national shift towards a neighbourhood health service. And you will have seen Secretary of State talking about this and talking about a new era for the NHS and a new iteration that we're moving towards. Really important to have a population health understanding. We know that our population in Greenwich more than anywhere is very diverse, not just diverse in terms of ethnicity, religion, diverse economically as well. We've got real poverty. We've got some massive houses I'd love to live in one day. And of course, background as well, people's interests, how they want to engage, how they want to use health services, how they're linked into their communities, all very different and a very variable patchwork depending on where you look. Related to that, we have many what I'll call community assets, and what this is voluntary sector, community groups. It might even be the WhatsApp group that you're on your street, or buildings that you access for youth club in your area. There's lots and lots of community assets. And the purpose in my mind of neighbourhoods and why this is different and better, to the earlier question, around some of the, or promising rather, to some of the models we've had before, is this is rooted in community. It's not about saying we have a health service, this is how we've always done things, and what we're going to do is we're going to try and put a little bit extra into that. This is actually making it very central to what matters, as colleagues have talked about, to what matters to people, and to understand what their perspective is. Mike referred to living the life that people want to live, and understanding that. At the core of that is thinking about health inequalities as well, and health equity. Really important to have that understanding, and impossible to have that understanding without really drilling down into some of the drivers that we see on what I would call a kind of quite a micro or hyperlocal level. So to bring this to reality, you can't just kind of say, we've got some great maps, we've got some great principles about how we're going to encourage social well-being and bring in kind of non-medical assets. You need to demonstrate it through improving the services and the pathways we have. Rachel's actually talked about this really eloquently with the frailty service that we have at the moment and the work it does, not just medically with those frail people, but also with the voluntary sector. This is really important. At the moment, we have Age UK plugged in. In some of the development work that we've been doing, the theme that comes out over and over is around loneliness amongst people who are frail. And again, that came out in the helpful question earlier. Not loneliness in a way that will be solved if you go to a befriending service, although those are very good, but actually something quite entrenched around the way people are living and accessing their communities, speaking to their neighbours, possibly with a carer, but actually where that's not the case, being able to make sure that people are plugged in a way that is meaningful social connection. So that's important. So the frailty pathway is being developed at the moment. We're looking much more at proactive care, and I think previously we've sometimes thought about proactive care as being relatively younger people that we can kind of get in, do lots of the lifestyle interventions with, etc., and then they won't get poorly. But actually, even all the way up to end of life, you can do proactive care to help people to prepare to stay as well and independent for as long as possible. The second priority pathway is around people with multiple long-term conditions. So we know that there is a window of opportunity where people who are diagnosed with one long-term condition, maybe another one follows, maybe there's some related things going on, how they can be supported. This ties in nicely to the previous question from one of your councillors around dependency and actually really empowering people. I was speaking to a GP recently, went to visit a surgery, and she was talking about when you diagnose someone as pre-diabetic, that is the sweet spot that you need to work with that person to really understand not just the usual things that you would convey as a doctor in the surgery, this is a healthy diet, do some exercise, etc. Those things are important, but also to link in with peer support groups, link in with others who are maybe on that similar journey. Actually, a lot of people now prefer digital. What are the apps around managing potentially diabetes and managing your health better? So some of those inputs. So we're looking at our long-term conditions pathway. We're linking in with some of those wider things that affect health as well. So we were talking before about loneliness. Also true with younger long-term conditions, residents with long-term conditions as well, as loneliness isn't just older people. Also looking at employment support as well, and people actually maybe struggling with 2 or 3 or 4 conditions but wanting to be in work and needing that extra support. People who are very keen to volunteer and work with others as well. So something around that cohort of people will be particularly looking at people with cardiovascular disease, because that's one of our big priorities in the borough, and also chronic obstructive pulmonary disease as well. And then finally, our third priority pathway across all of South East London that we're focusing on here in Greenwich is around children and young people. At the moment, there's many common conditions. I'm thinking particularly of eczema and asthma, but there are others where there will be support in general practice, of course, to those families, to those children, to those families. But we're seeing a lot of people referred to the hospital and then maybe waiting for a long time. 6 months in the life of a child with asthma is a really long time. So we're piloting in one part of the borough at the moment, in the west of Greenwich, a local child health model that brings paediatrician expertise into general practice, so almost the inverse of the frailty pathway that brings geriatrician expertise, and the long-term condition that brings the diabetologist expertise. This is around bringing all the ologists out into the community, paediatricians in this case, and working with those families, also upskilling general practice as well to be confident with managing children. Those are the 3 pathways that we're working on at the moment, and very happy to come back and talk about to the earlier point around some of the measures of success, and how you know kind of I think you called it the real life impact on the person, on the resident. We're also, as a related point, we are looking at how urgent care, so I don't mean emergencies, but urgent care when you need help on the same day, can be delivered at a neighbourhood level. And this hasn't, we've got additional appointments in general practice that try to do this, but it hasn't necessarily been in the same way with that critical mass. And to the earlier question around, Mr. Kenny referenced the pressures in the hospital. One of the key parts of the government's policy at the moment is shifting people out of hospital in the community. Lots of what we're doing around proactive care is looking at that, but actually in a really direct way, having same-day appointments in general practice, having really good access into pharmacies, having 111 directing people into the community, having an urgent treatment centre that, although it's based in the hospital, is able to direct people out. Those are all really important, and that's the only way we're going to cut off the source of the pressures in the hospital. So finally then, the final bit I wanted to touch on was around our progress with integrated neighbourhood working around our estates, a really important enabler, and we're looking at, as per the national directive, having a neighbourhood hub in each area. Some parts of Greenwich, it's relatively easy. There are buildings that actually are quite neighbourhood hub in the sense that they're offering not just health services, but social care services, other local authority provided services. They have voluntary sector organisations and community groups in there. In some parts of the borough, that's not the case. Actually, we don't have great buildings. We do have sites that aren't really what you would call modern facilities. So we're looking on that and making sure that that's important. Colleagues have talked about the workforce and the way we're working with our teams and making sure that and again, really good reference from the question from Mr. Kenny around the staff being up for this journey, although it is scary and destabilising, and we've seen many restructures. Actually, people realise the situation in the NHS, the pressures, the hospital's been mentioned, but in general practice it's really difficult. In community teams it's really pressured as well. People don't want that pressure. People are dropping out of social care. People are dropping out of GP training, for example. So we need to kind of work with people who are our workforce in the system to work through that. Digital as well, really important that as we move towards the future that we are digitally connected. I won't go into the boring points around how organisations develop kind of digital interoperability, but really important. One of the things that I think more and more about is around digital connectedness being part of the solution around loneliness as well, and actually people feeling digitally connected, even if they're in their own home, does help with some of those anxieties. And it's not just older people who might be lonely, actually new mums at home, people with serious mental illness, having online community can be really positive. So some benefits there. There are, I think colleagues are talking about the adult social care redesign, how that supports neighbourhoods have gone part of the way there, and thinking about the I don't want to use a long NHS jargon, the DHACT programme, so the digital health and care technology. So Lisa may want to come in a bit on that, but just to wrap up my bit then. So I've spoken to you a bit about what the neighbourhood working will look like in Greenwich geographically, and how the system as it stands will layer on top of that. Or it will become part of that. I've talked about some of the priority pathways, and I've talked about some of the enablers of how we're going to get there. There's no quick fixes and short timescales. It will be a revisioning of the way that NHS, social care, all of our system partners work together. But really importantly, for me, this is kind of the step change. It's about putting social well-being and the wider well-being of the person at the centre, and really increasing our capacity around that. So where we'll be at in a year's time, in 5 years' time, is our voluntary sector, which in Greenwich is fantastic. There is so much going on out there. We'll be plugged in and we'll be able to, there'll be a lot of awareness of what's available out there. We'll have the commitment of all of our partners to see the job they're doing as not just running a hospital, not just running a GP practice, not just running a pharmacy, but actually contributing to that population health, and how the knock-on impacts can help to improve health overall. And then finally around patients individually and collectively, to really have that empowering, Mike talked about being anti-dependent, and have that empowering conversation, have that open conversation that makes people feel like the system is there working for them. So that's a high-level summary of lots of work that's going on. If colleagues would like to add, please feel free.
Yeah, you want to carry on there?
Yeah, I'll keep this bit brief because I know we've spoken a fair bit. So just to link up some things. So whilst the national directive talks about a national change to neighbourhood healthcare, we're taking a deliberate approach to include health and care in these neighbourhood teams. So Mike is leading the work to redesign the adult social care operating model and make sure that that aligns with these ways of working, so social workers can sit alongside other practitioners in those neighbourhoods. We were also working on our home care transformation as part of this programme, because we know there's great opportunity to think about how those workers that are going into people's homes may link better with district nurses who also go into people's homes, but also the tasks that they do. It might be that we can think about actually the workforce we need for the future being a bit different in that transformation of those services as well. And I mentioned the reablement review that links to that. So we're very deliberately now transforming together rather than thinking about this neighbourhood health service and then social care or other voluntary sector services separately. And the Healthier Greenwich Partnership, which is our local care partnership overseeing this work, is really committed to that because we believe in actually doing things together is much better. And it's not really about the badge that people wear in the organisation, it's the person in front of them and the task that they do for that person on that day is the trust that they build up. And sometimes that's better trust with the voluntary sector than it is with the public sector. So part of that neighbourhood approach includes public health as well. Sam couldn't be here tonight, but she did say a couple of words for me to share. So she was saying that the public health programme around change are making sure that we recommission things like our Live Well service. We think about the links with the frailty pathways that Jessica's mentioned. Sam and her team are working on a kind of wider prevention offer into this work as well, which is really important. If you bring all those ingredients together, you then think actually what is the Greenwich pound being spent on and how do we change? But also to John's point earlier, some of this may not be about big reorganisation. It's also about how people align in those areas. So we don't know yet what the workforce disruption might be, but we're really sensitive to that. We're bringing together networks of the workers to really tell us the realities of the day-to-day for them. And also a workforce board, which I think I mentioned here previously, is being organised in the borough across health and care, and things like our workforce recruitment, retention, development, all of those things we're trying to join up around this as well, and really be future-proof about it, as well as the ethics of how the workforce are treated today, and doing that collectively.
Thank you. Thank you for your presentations. I will now open for panel members to ask questions. So, Councillor Sarah Jane Merrill, if you can.
Thank you very much for that. It all sounds like music to my ears, so great. Thank you, really. I've got lots of things I'd like to ask, but I will keep it brief. The first thing I suppose really is more of a comment. You talked about the importance of the voluntary sector. You talked about loneliness. You talked about age concern being an obvious partner there. And I don't know how you would do this, but I would hope that going forward your plan would allow for support for those organisations, which helps them to not diminish their operation because of external circumstances. So like, for example, I will give an example because I think it's really important. Age Concern operates within my ward in the Eltham area, and I know it's in a building which is ours, we haven't made a decision about, so Age Concern's struggling there really to work on the building. Park that for a moment, but also the knock-on effect of that was that Men in Sheds had to move out, and that broke my heart because it is such a valuable organisation, and the amount of people who attended it and overcame loneliness as a result of that and found a purpose in their life, only really for that organisation to be cut off, by the knees, which sort of runs counterintuitive to everything that you were saying. So it's a loose question, which is, how could you build that in to your thoughts going forward on working with organisations like the Royal Borough of Greenwich, for example, whatever else, on a wider sphere to support them and help them through that process? I know, of course, money is the key to everything, and that's short, and that's the second question, and I'm sorry, I'm just very interested in this. But you talked about looking at building neighbourhood hubs. And again, I assume that comes with a considerable cost because you have to fund a site, etc. So how far down the road are you on that? And I guess, like, funding is going to be fairly prohibitive there because we all know there isn't a lot of funding about. And the last thing that I was really interested in, you were talking about urgent care, reacting to people's urgent problems on the same day. And you talked us through that a little bit, but I wondered if you could just pluck out of the air an example and talk me through how that would work and who might see them, under what circumstances. I've got more, but I think that's enough for the moment. Thank you. Thank you.
Okay. Thank you, Councillor Sarah. Go ahead, you can answer now. Thank you.
Thank you. Thank you very much for your questions, Councillor Merrill. The last question around pluck an example out of the air sounds like an exam question or an interview question, but something has come to mind. One of the things that we know has a lot of future potential is the way that 111 works to support really good same-day care, so people have a lot of confidence in it and are getting to the place they need to. We know those services will come up for re-procurement at a point in the future. We've had in the past in Greenwich where the 111 service was so inundated that they asked the local GP Federation to take over for a period of time and run those 111 where you phone. NHS Direct as was. Sorry. Where the local GP Federation was asked to take over to field those calls. And when that happened, the amount of people who were not then sent to hospital but were kept locally, either in their GP practice, pharmacy care, community care, was much higher because the people answering the telephone were the ones who knew Greenwich, knew about Eltham, where that person lives and what was available. So that is one example in my mind very clearly that we want people to be using 111 rather than just get in the car and go to the hospital or giving up on the telephone at the GP practice. But actually, when you bring care nearer to people, whether that's Greenwich or Eltham specific or neighbourhood specifically, as we're talking about, that has a much better impact. So that's one off the top of my head. On the neighbourhood hubs and the money, it's not as impossible as you might think, actually. So what we're looking at is the buildings that we have at the moment and the functions that they have, but also where there's underutilisation and where for a relatively small amount of money you could kind of reconfigure. And actually probably in 3 out of the 4 neighbourhoods, that's the route we'll go down, where there's that most promising opportunity and we can refurbish and repurpose. There is probably one neighbourhood within the borough where there aren't any obvious candidates to do that, and it might be a new build, but that would be kind of one new build rather than many. And also in terms of, in terms of where that money comes from, the NHS doesn't have pots of money available for funding, but we are in a borough of a lot of development, and Lisa knows better than anyone around the Section 106 and the community infrastructure levy payments that we get from developers when these large buildings and areas are developed. We can use that directly for healthcare. So that's the plan, to actually benefit from Greenwich being an area of such high development. Oh, sorry, there was another question around supporting the voluntary sector as well. This is a really difficult one, and I don't think it's one with a short-term answer. In the short term, we're working really closely with the voluntary sector as equal partners, but realistically, we all know that things like buildings and where voluntary sector organisations are set up, their workforce often on short-term contracts because there aren't short-term contracts for that organisation. And the vision is that actually when you incorporate the voluntary sector into the pathway of how you're delivering care, not a nice add-on that you might signpost to, but actually part of that pathway, then the funding follows that. If in the future we're redistributing funding out of secondary care, out of the more acute end, and moving that into the community and moving that towards primary care, then I would hope very much that they would benefit. I also think we need to do work with the voluntary sector, probably in most parts of the country, it's not necessarily Greenwich specific, around coming together to collaborate and to provide a bit of, what you should call it, risk, de-risking by working closely together. There are models out there, including in South East London, of voluntary sector organisations federating, so actually becoming entities that can hold longer term, larger contracts and have that stability. So I'd be quite keen to do that, and colleagues may have a view, particularly on voluntary sector.
I think that really links to some of the work that wasn't specifically in the report because it's fairly early days on it, but what we want to do with the Healthier Greenwich Partnership is really make sure the voluntary sector are at the heart of our work, as Jessica said. But that work will enable us then to think about what are the kind of legal models that we could support and facilitate those organisations to learn would actually support their sustainability. So we're going through that development programme, which is going to be quite exciting in that, I think. Public Health also do the commissioning of the infrastructure organisations. So you'll be aware that we've got Metro, GAVs in the borough. There's a move towards thinking about what our future infrastructure requirements are. So Council for Voluntary Sector Services is usually that, you know, providing that grant sort of support and signposting or governance and things like that. And having worked in that way back in my career rather than where I am now, I'm really passionate about that. And I know Sam, our Director of Public Health, is. And working with those organisations now is really important to think about the infrastructure they need. So that work's kicking off. Two other things, we have an NHS charity fund locally. So we do have the ability for people to bid for funds from that, and there's a groundworks organisation who facilitate that for us. And then we also have our own voluntary sector grants programme, which many of you will be aware of. Sam in Public Health is now leading that in terms of the future. And we're working with Mariam in terms of her steer over, you know, where are the things that the voluntary sector are saying they need in terms of capacity building and the sorts of things that you spoke about. Out of that, there may also then be opportunities for partnerships with the voluntary sector more broadly, bring inward investment. You know, they can often get social investment funds we can't get in the public sector. So this is all us thinking about what is that kind of Greenwich pound point that I made and how do we bring in more investment using those partnerships positively, because we can't always do that alone. So I think that's really exciting because it kind of links up to this partnership approach that we mentioned before. Hopefully that answers the other aspects. Yeah. Oh, one other point, sorry, really important point that I didn't mention earlier on. We are absolutely committed to working with residents, and the voluntary sector are a fantastic resource in terms of their connections, the faith groups and all of that. So we know Health Watch is, sadly, as part of the national policy changes, as Joy, I think, mentioned last time, looking at whether that is a disbanded organisation or a statutory role. But locally, we're working with Health Watch to understand what their aspirations are as a charity beyond that national policy change, because they know they're rooted in the community. Beyond Health Watch, we also have our own kind of co-production engagement teams across different organisations, plus, really importantly, what John and colleagues said in terms of the foundations of those different groups, patient groups, things like that. We've now got a network of those people coming together to say, how do we get out in communities collectively to understand what's important to them and do that kind of systematically, and what is the capacity building for that as well. So these integrated neighbourhood teams aren't going to be designed solely by us. They're designed in partnership with our residents, and we're already on that journey, having conversations with residents about what matters to them. So we mustn't forget that, because actually we can't design things without people, because we are people-based services.
Thank you for those answers. Do we have further questions from, yes, Councillor Spencer?
Hi, thank you for your presentation. I just have a quick question on the workforce, and I guess it's around whether if we, the divide and conquer method that we're using, if we have enough skilled local workforce to actually enforce this, or will it lead to sort of staff being drawn away from other services in order to cover others?
Operationally, it might be worth, from a social care perspective, Mike talking about some of our recruitment and retention and our positive stuff around there. And Rachel, obviously, in community services, I think operationally will have a view as well.
Okay, yeah, the workforce is the key to making this successful. In the redesign, I'm currently taking part, which aligns totally with what you've heard around the sort of primary networks, is we are developing, and it sounds a strange phrase because staff have been in post for a long time, but we're developing an induction program for them to bring about the new ways of thinking and the new cultural ways, so we don't take it for granted that staff, just because they've worked for us for a while and we've talked to them, actually understand fully what we mean. So we're currently working with staff groups, with the trade unions, with our workforce development team, to literally re-induct some people who've worked in the borough for many, many years. But it's about new ways of thinking. It's about integrated ways of thinking. It's about the development of strengths-based work. And it's about how we reach out and utilise the community as the first point of interaction. So it's a very important element of the redesign we're doing across the piece. As I say, it sounds a strange phrase, induction, but it's about induction into new, not induction into a deficit in what people know. Because some of the staff in the programme I'm working on, you know, have really concentrated in specific areas, and so whilst they may have the same qualification, they haven't practiced the same sort of, for argument's sake, court work, court reports. You know, it's been done in one team. So part of the equalising of activity around the neighbourhood is making sure all staff are able to do court reports. That's just an example. But so it's bringing the workforce with us. And it would be fair to say that one of the points, and I've shared this with Councillor Oliver, is actually in the programme of work I'm doing, the staff enthusiasm behind it is phenomenal. You know, in over the road in the centre, we've got a room where we put up the redesign, and it's loaded with post-it notes from staff. You know, it really is worth going over and having a read to see the positivity of the staff around this new way of working. It really is quite an enthusing and sort of heartwarming exercise to go in that room and read what staff are saying. And we've agreed with the director, Nick, we're going to leave it there for a while, because it's like a celebration, you know, and it's celebrating the staff's desire to get there. But we've got one particular sign up, and they've written this, that sort of says, can't we hurry up and get there quick? You know, and but in a positive way. So workforce is essential. We are targeting them, we're including them, and we're making sure that they're equipped on the journey and making no assumptions that they know exactly what we're talking about. And that's not just within adult social care, that we've done it, you know, with children's housing, voluntary sector. It's about reaching out and making sure we're all equipped for the future. Because we will be one workforce, one way or another, with the same focus, which is the person at the centre. We may all work with different groups and different titles and different badges, but actually the person will be at the centre of everything we do.
Thank you, yes. Rachel, you want to add?
Yeah,
Okay.
just briefly, because I know time is ticking, isn't it? So we, I mean, you know, from a health point of view, we partnership with University of Greenwich for our nursing students, and so we have really good recruitment for nursing, and South Bank University for our allied health professions. So we've got really good relationships, and I think to Mike's point, really, we spend a lot of time developing the careers of staff and making sure we've got opportunities at all levels, so apprenticeships, right the way up through to career development, volunteering as well. We have too. I think we've spent a lot of time in Oxys looking at celebrating our workforce and kindness and compassion, and making sure that we are a really attractive organisation. And it has paid off, because we do now have a lot of people who want to come to work in Greenwich who might have worked up at Guy's Hospital or in other parts of South East London, and that's been helpful. Certainly the tunnels have helped us as well in terms of recruitment. People who live locally have come back to work locally. So yeah, that's been we've seen good recruitment recently.
Yeah. Go for it, Jessica.
Thank you, Chair. Just briefly, one of the risks is around we have 29 general practices across 40 sites, and they've all got their own workforce as well. And the average working day in the life of many of those staff is they go into the surgery, they do their day of work, and they go home. They don't necessarily come to kind of some of the workshops or the events, etc. So what we are doing is visiting and reaching out and speaking to groups of staff within those practices. We have a conference coming up specifically around neighbourhood working and how that will impact your average general practice or other part of the system. It's not just around general practices, but seeing that as a core, and many people coming will be thinking, how does this affect me? So that will be important. And then the ongoing mechanisms. The other part of the workforce, I'm conscious the hospital isn't here to represent themselves, but certainly in some of the long-term conditions work that I mentioned, where we've got diabetologists, nephrologists looking at kidney disease, coming out, working in surgeries with the doctors and nurses, they've been really, really positive about doing it. And even when the pilots have come to an end, they've carried on doing that. So there's also something about rethinking what your job is. If you're a hospital clinician, that actually maybe that's not always in the hospital, and you'll be out kind of working with your your peer clinicians and working with maybe social prescribers. You wouldn't often get in the same room someone with the expertise around diabetes with the social prescriber who knows all about the voluntary sector support for that person. So we're trying to bring that together with those groups of staff as well. That's a good question.
Thank you. Yes, Lisa, go
I'll
ahead.
keep it brief. I think I
Okay.
mentioned the workforce board earlier on. We know we've got a profile of ageing workforce across health and care. That's common across the country, and obviously people go into retirement. We have to have a throughput of people, but also with those skills. And I think you mentioned that, you know, what is that skill mix that we need for the future? What have we got today, and how do we encourage people to come into the sector? So Rachel mentioned the partnerships with universities. So what we're hoping is that our future approach will be about understanding our workforce strategies collectively, so that we don't kind of rob Peter to pay Paul type stuff, because we do know that happens in the sector, and particularly around pay as well. And there are really, you know, inspiring young people coming through who are now understanding a bit more about care and health and the different variety of roles. You know, when I grew up, it was like, I want to be a doctor or nurse. I wouldn't be saying that now, because I understand that there's a range of roles to support people in communities. So it's about inspiring that next generation as well, so that we can get the kind of throughput of people.
Councillor McMurrow.
Thank you, Chair. Sorry, very briefly. Did I hear that right? The tunnels, the Silvertown tunnel has made it easier to recruit more people, is that?
I don't have any data on that, but certainly people commuting through, we have, historically, people have maybe lived in Greenwich and commuted to the north of the river, but we have seen more people applying who want to kind of not commute and have to pay through the tolls, yeah.
What a fantastic benefit of the Silvertown tunnel.
Boost the local economy.
And yeah, boosting the local economy and the public sector and health service. I'm just waiting for David Gardner to tell me he was in favour of it all along.
He planned it.
I think that's actually a very good point you've raised. Is there any other question from anybody, panel members? I think I wanted to say the population is increasing. That is the biggest thing. And demand for care is also going up, especially when it comes to the elderly. We are living long now. We have adults with disability, terminally ill people. I just wanted to say, I think on the point that Councillor Merrill spoke about, voluntary organizations playing their role or making sure we get hold of them to help. I know how the Befrienders are doing so marvelously well in the community. I know how Red Cross is helping Age UK, and all these people definitely needs to be supported so that we are able to stop people from even coming to the hospital. I'm wanting to find out that with this increase, and of course with the new development as well along the River Thames and whatnot, Greenwich has become a point of where, like you spoke about the Silver Tunnel, also the Elizabeth Line has made people to actually, possibly decided to make this place their place of abode, because it's easy even from the city to just come around. With that increase in all that we are looking at in numbers, in development that we are doing with people coming because of the attractiveness of the place, what are we doing on the part of primary care? Because when it comes to the GPs, we know that we are already struggling. The numbers are not that great. People are lining up to go to A&E because they are possibly trying to get hold of their GPs, and it's a problem. So how are we tackling that? That's the first question. And the other last one is about the long-term conditions, people with terminal illness and those especially vulnerable elderly terminal people, and also elderly people and adults who have disability, for instance. How are we tackling that to get them the better care that we all want? Thank you.
So general practices has been working on a number of different ways to do exactly what you've said, Chair, to try and make sure that people have timely, good quality access to the care they need and they're not going to hospital. I think there's two groups of people, two cohorts that we need to be mindful of. There is a group of people who go to the hospital because they can't get a GP appointment, they can't get the access they need, but there's also the perception that they can't. Maybe that's a founded perception because they had a bad experience before. Maybe it's because they're headlines and not necessarily trying to get with their GP. And I think the challenges with these two groups are different. In Greenwich, all of our primary care networks have made the nationally mandated changes, and they've made them within the deadlines. So these include improving the telephony system, so that's working better for people, providing extended access, which is basically extended hours of appointments during the weekends and in the evenings, and having systems in place to make sure people are signposted to where they need to. So that's almost the standard that if you were in any borough, you'd be asked to do, and all of our primary care networks in Greenwich have been doing that. We've also got a number of practices who have taken what would have been considered at one point to be quite a leap of faith in changing the way their appointment system works very radically. And that includes moving to a system called total triage, which means the total amount of people who contact you will be triaged, and that's usually through an online platform where you put in what's wrong and someone will come back to you. By doing that, practices are reporting significant amounts of time being freed up where they're able to get people to the right place they need to. The right place might be the general practice, but not the GP. It might be the nurses, it might be the pharmacy, it might be the social prescriber, it might be the physio, it might be the mental health practitioner that we have all of those roles in our practices. So that's taken quite a big amount of demand and said, these are the places you need to go. It's then freeing up the face-to-face in-person appointments with a GP that you need with their skills for. And it's meant that practices are able to look at their work planning around what I was talking about earlier, the proactive care, to look at people with multiple long-term conditions, and rather than wait for them to come in, have the standard 10-minute appointment to talk about those conditions, to actually do some outreach to them proactively, to talk to them, to make sure they have their checkups and to talk to them about management. And I suppose from my perspective, bringing some of these things together, we need to make sure general practice is accessible. It needs to be accessible for the long-term conditions, patients that we've mentioned, the frail, the elderly, anyone who's at rising risk of escalating into hospital or escalating with their mental health condition, for example, because their physical health is so bad. The whole group of people out there, the access needs to work for them. It doesn't need to work for people who don't need to be there. And that's sometimes a hard conversation to have because people are used to kind of doing things the way they've always done. Go online if you can, see the pharmacist if that's the best thing for you. Actually go to the pharmacy. We now have nearly all of our pharmacies, I think it's 57 out of 59, offering the Pharmacy First scheme, where for a number of common conditions, you just go to the pharmacy, no appointment, and get the help you need. So I think there is something about a really honest conversation that it's not just more GP appointments that we need to get smarter, and that is happening. Some of the practices doing total triage and other things are really, really getting there and seeing the difference. But of course, it's discretionary. We can't enforce that. So we are working with practices to think about what's the right model for them and what's the right timing for them as well.
Any other question from anybody, from members? Okay. If I can give you 2 minutes each. Kenny, that's your name is. Just mention your name and then ask your question if you come to yes.
Hello, everyone. My name is Ömer Aksoy. I've got a son, 19 years old, who has got a condition. So I'm just going to talk about him so that as to give you, some ideas, if you like, of what an individual condition look like. And I hope this will speak also to the difficulties, as the individual is universal, so it will speak the difficulties so many individuals and the families face. So my son has got this progressive condition with extremely complex needs, right? And then he needs like 24/7 care, just looking at my notes. And I'm the parent carer with my wife. She's also the parent carer. And we got like 12 hours of, care system, if you like. We got a carer, which is only partly paid, who is only partly paid by the council. So we have to pay ourselves the remaining. And, like, we are extremely tired, right, as parents. And plus, we are getting older while my son's conditions is, deteriorating, right? And we can't even keep up with the clinical appointments. It looks like, because it's complex care he needs, it looks like a full-time job. And we have to work as well, otherwise we will be mentally ill as well, like that. And we didn't get any respite. Could you imagine, in the 20 years of time, he had only 4 days of, respite care, which is the daytime, and 1 night, actually. 20 years, right? We never get any respite as parents. And we are forced, to go to holiday individually, because the other has to stay home to look after my son. And then the person coming from holiday finds the partner completely, on the floor, I'm talking about, So we have no family members in this country to help us as well. He was doing creative media last year at the Southeast Colleges, London Southeast Colleges, and he has been discharged from the mainstream education. Either there is no PA support for him, and then we looked for colleges, right? And then there is no either PA support or the college is not fully accessible, like no changing places.
Just to intervene, could you just sum up now, because it is a very important kind of study case, but we want to make sure that if it's a question, they will answer. If it's a case, we will make sure that it's directed to the right person to deal with, but not to discuss it in its totality. So please, could you just sum up if there was a question you wanted to ask?
Sure, and the social worker, just quickly mention about, it's been, no good record of communications, and it's been all the time changing, every year, twice a year, and then we have to start from the very beginning to tell our story. We are talking about like integrated care, system. Where is the integrated care system? We have to tell our stories from the beginning, and it's very, exhausting.
Yeah, I think the message is
okay. So what we need is like this summary. His CHC application is being rejected, right? And we lost the EHCP, his EHCP, because he left the mainstream college. We lost 27 hours of support when he was at the college. He got this support, and we need. Okay, so would you? Okay, so my question is, would you be able to provide the CHC entailing PA support, minimum 24 hours of care to be paid, and the respite support? That's all I've got to say. Thank you very much.
So as I mentioned, this is like a casework. It will be directed to someone specifically to look at it. This forum It is, I mean, we thank you for sharing your situation, which is really, really very, very, you know, we empathize with you, but please,
just a quick answer, sorry about that, the same, you know, the situation I explained in July, and Nick Davis,
yes,
the director, and he just, you know, I emailed him, and he just sends this email acknowledging receiving my email, but nothing has been done.
Yeah, so this is that's fine. Thanks for the message. We will make sure it gets to the right person. Did somebody want to make a comment? Because this is a case, a personal kind of case. It's not something that we.
The only comment, Chair, to make is that I'm very aware of this case with Nick, and thank you for raising it here. It is casework, and we are dealing with it, and I do know that the social work teams have been in touch with myself and Nick about the next step. I also lead on CHC, so I'm very aware of the process, and we can direct our resident to the support in terms of how to appeal on those decisions, and that will be part of our casework.
Yeah, and as he rightly mentioned, he did mention the same thing in July. So I think it's for someone to actually have a look at. Francis, can we give you the last? Please just go straight to the question, and then because we should be finishing in the next 5 minutes' time.
I would like to.
When she finishes, you can, yeah.
I just like, I don't know if you know, that in 2018, we had 48 GP practices. So we've lost nearly half. So there's, first of all. Secondly, the GPs can't refer straight to a consultant with people with on the MSK, and that's spinal, etc., etc. They go to the MSK, they have an MRI first. I presume the GP comes at their cost. Then they see the MSK, I presume, well, I saw one, but I didn't think he was a consultant or doctor, but anyway, that's my opinion. And they make the decision whether you get to see a consultant. And I had, so therefore, the rights of the GP has been removed. And this is outrageous. I was under Guy's consultant, and by default, somebody discharged me, and the head of the appointment said, you won't discharge. I have not been able to get back. That's just a point. And the changes of the community neighbourhood healthcare is actually another step to privatisation. It shows you that I saw my GP's physiotherapist thinking to get massage. She said she couldn't touch me because I'd deteriorated, but she has to go back to Circle again. I said, I'm not going. I said, it's ridiculous. So this is the American system that's actually practicing now, and you'll find that the new neighbourhood group is another step forward. This is my opinion, and the evidence, I've just showed you some of it. And this is why people are very distressed. What with the reduction in GPs, which is planned, it's all planned, and now doctors can't get their training, and there's loads of GP wants to go on the training, and they can't get the jobs.
Thanks, Francis, for your opinion. And did somebody want to make a comment? It's not a question. She's actually speaking about her opinion.
I think, so I've worked in Greenwich for 18 months. I don't know about the history with the 48 practice previously, but there is something about the small standalone practice needing to be resilient. We work closely with all of our practices. Some have got 3,000 patients, some have got, the biggest one's got 33,000. So we are really committed as part of this, and I am tomorrow coming in for a meeting around how we do exactly this, to making sure that general practice is resilient and sustainable to be able to provide the care it needs to. When a practice closes, it's incredibly sad and difficult, and it's something that we take every step to avoid. Of course, sometimes the number goes down because practices merge, and that can be a really good thing as well. So point noted, but also lots going on to make sure practices don't fold.
Thank you, Jessica, for that response. Yes, I come to Councillor St. Matthew Daniel.
Thank you. Now, I just wanted to ask somebody to help that gentleman that was here, because as he said, this is his second time. If he's coming here repeatedly, that means he's not getting the help he needs. So that's why he's coming here, to share the information. So can we please help him to stop him from coming here, because he shouldn't be coming here, because he's sharing his personal details here, and he shouldn't have to do that. So can we please do something for him, please? Thank you.
Chair, I don't disagree, and we are aware, as I said, we're aware of the case, and it is being, and I completely agree, we don't want that situation happening, Councillor Matthew Dandis. It's not really what we want to hear in these forums, but I do want to support that gentleman to understand, and Nick is in contact as well. Thank you.
Thank you. And I think after this we'll change, put some emails across or telephone numbers to be able to be in contact. And if you could also follow that up, that would be great. Just to make sure that the right person has dealt with it. Yeah. That would be very helpful. Yeah. Because, like he said, he was here in July, and then we should have solved this problem. Yes, I will. Is there any member who want to make a recommendation from this? Is there anybody with any recommendation, further recommendation? If there's none, I would like to say thank you very much for your presentation tonight. You've been very holistic in covering everything regarding discharges and also ICB. I think ICB was here the last time. It was on financial basis, but today you went deep into the work that you do and the rest. So just keep on doing what you are doing, and let's see how best we can help the community. Prevention, definitely. We don't have the public health person here, but prevention is definitely something we all have to and also support the voluntary sector, because they are the people who can prevent and save the NHS a lot of money. So whatever money we put in for them is going to be yielded positively to us. So thank you again for your presentation tonight. I will move swiftly to Agenda 7, which is the last one, commissioning of future reports. The panel is asked to note the work items that are scheduled to be presented to the meeting of the Transport and Place Scrutiny Panel taking place on the 27th of November 2025. We have Director of Public Health Annual Report focusing on health inequalities and food strategy. So if we can note that. Is it noted? And if there's no any other question, thank you all for coming. And yes, have a blessed evening. Thank you very much.